your patient can vomit while you're trying to intubate them. That's a mess. It does happen. Turn your patient to the side. Sharon's shaking her head back there.
Don't be on the side that they turn the patient's face.
Huh?
Don't be on the side where they turn the patient's
Oh yeah.
face.
If that happens, you're gonna immediately welcome. You guys want to just put your stuff down to the side? Huh? I couldn't hear.
You're dodging saliva. Matrix.
Oh, a lot of secretions? Yeah.
No, we're talking about you're staying away from the.
Oh, sorry. I wasn't quite sure what you were getting at there.
None of us are.
Got it.
We'll get that a while, Jeremy.
It's okay. So anyways, those are some complications that you can see come up. But pretty much, unless they're DNR, DNI, or we just can't intubate because of facial trauma, we're going to be able to intubate somebody, and there's not going to be a lot of reasons that we wouldn't do it. It's possible that we won't be able to get the tube in, but that's a discussion for another day. So let's talk about the supplies that you need. Most of these should be listed on your slick already, but of course you need an oxygen source. People always assume that that's an automatic, but what if your patient codes in the front lobby?
Yeah.
Those are the worst. In X-ray, in lab, places where patients are not meant to code, you might not have always have oxygen available. So at some point you do need an oxygen source that you can hook up to. Of course you need your ambu bag with mask. Again, this is the type of ambu bag that we can bag somebody, manually ventilate somebody. People don't always like bag, they say we bag bodies, but I've been calling it that for a billion years and probably will continue. We can manually ventilate somebody with this type of ambu bag because it's not a free, Yes, thank you, self-inflating. It's just, we can do it on our own. The self-inflating bags require oxygen to flow into them. They're very flat, and there's no way, you'll see them in neopeds. They're super flat, and there's no way you couldn't bag anybody. You need an oxygen source coming in. So these are able to, so if you don't have oxygen, if somebody does code in a weird place, then you can bag them until you can get oxygen hooked up to them. And we take the hoses off here, just because they get in the way all the time, but you would obviously have an O2 hose on the end of this O2 tubing. And how are you gonna run this at? How many liters? 8? How about flush? Flush. Ambu bags, flush. Flush the flow meter. We want it 15. The other thing that's very important for you, most of the time you will not be the first person to the scene unless you happen to be in the room. So they're removing a lot of airflow meters from patient rooms because we've had a lot of problems of patients being hooked up to air when they should be hooked up to oxygen. But, and literally even in codes, patients have been hooked up to air the entire time instead of being hooked up to oxygen. So do be wise to the fact that if you come into the room and you're not the first person in the room, where are you gonna go? You're the RT. Head of the bed. That's your spot. Your job is to go to the head of the bed. So if there's another RT there, then you can assist that person. If there's not, then you're to take over because that's your job. So if the nurse or whoever say, I'm here, I'll take over now. First thing you need to do is make sure that this ambu bag is hooked up to oxygen. Don't assume. That's one of the biggest times mistakes happen, is because someone else hooked it up and you came in and took over and you didn't check. Anytime you come into a room and take over anything, you need to make sure that things are the way that they should be, because once you take over, it's now your responsibility. So if you took over and the ambu bag's hooked up to air at 15 liters, when the code is over, it's now your fault that that happened. And I don't like to use the word fault, but you get what I mean. It's, you're the person, you know, we don't know who, somebody started it that way, but you ended it that way. So your name would also be in the incident report, because that would require an incident report be written up, because that's not appropriate. Would it cause the patient's death? I don't know. Would it cause anoxic brain injury when we don't have any oxygen to the brain? Possibly so. So make sure that you're hooked up to oxygen. Anytime you come in, you always want to check that. So you see you're hooked up to oxygen, you take over bagging. So we're gonna put gloves on. Can somebody hand me a pair of large gloves? you get your gloves, you're putting them on as you go to the head of the bed. So we're at the head of the bed now. Mr. Joe's having a bad day. I just want to remind everybody the way that you should be bagging a patient. Remember, you need to do what do we need to do here? Head tilt, chin lift, right? What are we going to do if our patient has a suspected neck injury? Jaw thrust, which is really, it's hard to do this. If you're the one that has to hold, you're literally taking the jaw and moving it forward like this. And it takes a lot of muscle strength. There's actually a lot of things that RTs do that take a lot of upper arm muscle strength, ladies, so get strong. No weak RTs here. So if you're the person that would have to hold this, trust me, it takes a lot of, your arms would get tired pretty quick. But otherwise, head tilt, chin lift. Don't go back too far. We're gonna cut off the airway in the back there. You don't wanna go too forward. You're gonna cut it off the other way. So head tilt, chin lift. Nobody intubates by themselves. So as we go forward, of course, there's always gonna be other people in the room, but right now we're bagging. So your job is to bag the patient effectively, because as long as we can bag the patient effectively and our sats are okay and our patient's vitals are, well, they might be full code, but let's say they're not, and their vitals are okay, these people can take the time to get their stuff ready. It's when they can't effectively ventilate here that we have a problem, and we'll talk next term more about difficult airways and how we handle those. So remember, you want to do like a C. You're gonna take your index finger here, your thumb here. The whole idea is we have to make all of this seal around the patient's mouth, and so that all of our air is going in. Some people with smaller hands, you're not going to be able to get this whole mask to seal with just your hand. I have big hands, so I can usually do it. This also takes strength, so you've got to put your hand on the mask. Think about sealing this. These 3 fingers go underneath the chin, because that is what lifts up the airway there. And then you get nice ventilation from our patient. If you're someone who has a small hand, you're gonna probably get leaks out of this side. So use the ambu bag to your advantage and do it like that. So you're using your hand on this side to hold this side down, and then you use this to help keep pressure on the other side and lift up the chin. It looks like the patient's mouth is closed, but it's not. That's how you open the airway properly. Okay, so we're gonna just be standing here bagging while someone's getting all this together. So when you guys are practicing and when you actually do your checkoffs, there'll be two of you checking off. You'll be in your groups of 4 or 3 while you're practicing. So someone's going to be bagging. You're going to keep bagging until the patient is ready to be intubated. How long do we have to bag someone before we intubate them?
2-3 minutes.
Yeah, it depends on how long they're down. Generally 2-3 minutes. I will tell you that the standards you will probably see changing at some point. They're going towards recommending that patients not be intubated until they have a pulse, instead of intubating in the middle of a code. Because if the patient is not resuscitated, they don't need an ET tube. There's a main reason for this though. What's the number one thing that we need during we're doing CPR on a patient? What is the number one most important thing? Chest compressions and circulation. What do we do when we put in an airway? Stop compressions. So, and sometimes for a significant amount of time. So they're leaning, I think at some point, not yet, but at some point, and you may see some people that just don't, as long as you're effectively ventilating the patient, not put an airway in until the patient gets a pulse back. Because if they do pass away, they don't need the airway. So 2 schools of thought, you're gonna see both right now. But at this point, you'll see when you do ACLS, as soon as your help arrives, you're gonna go ahead and intubate your patient. So say you're in the room by yourself, or you're pretty much don't have a lot of people. As soon as the code team arrives, you have help, you're gonna intubate. So we're just gonna go on that route for now. So the person will be bagging. I have to stop, but we'll remember the person will be bagging as long as you're getting things ready. So that's as far as ventilating the patient while we're doing things. So let's talk about the other supplies that we need. So medication, if your patient's not a full code, you need your medication. So we have propofol, our white, in case you guys don't know, you'll see this hanging in patients' rooms. It looks white like milk. So you don't even need to ask what it is because it's the only one that hangs that looks like this. Why we call it milk of amnesia. So we have flumazenil, Ativan, Versed, any meds that you want to use. Propofol is one of the main ones preferred because it is what? Anyone know why propofol is preferred? What do you remember from pharmacology? Nothing. Oh my gosh, we're in trouble. Quick. And
Doesn't last long, right?
it does knock out respiratory drive.
Is it easily reversible?
It's easily reversible, yes. So propofol is very commonly used because it's a very quick onset and it's a very short half-life, which means it comes out of the system quickly. It's why we use it also a lot when patients are on the vent, because if we need to try to wean them at some point, we have to turn the sedation off. So propofol wears off very quick. So it's very common. Probably, I would say Versed is maybe the next most common one that you'll see. Propofol can cause significant drops in blood pressure, so we do have to be careful using it. If your patient is already very hypotensive, it might not be the drug of choice. We also have etomidate, which does not have as much significant blood pressure problems. So if your patient is very hypotensive, they might use etomidate instead. And that's spelled with an E. E-T-O-M-I, date. You've probably not heard of that one. So we also, yes?
And these are all which kind of, are these paralytics or
No, sedatives.
Okay.
So we're gonna sedate our patient, because are we ever gonna give a paralytic without a sedative?
No.
No, that's a bad day. So sedate first, then give the paralytic. That's the order it should be given in. You can't control what your physicians do. Make sure you know propofol has significant blood pressure effects, etomidate does not. So then for our paralytics, we have succinylcholine. You should know this name, right?
Yes.
I just remember it sucks to be intubated. So we use this very commonly to intubate patients. This is the most fast acting of them all. It has like a minute, and the half-life is anywhere from 3 to 5 minutes. So it's super short acting. So we use this a lot of times in what we call rapid sequence intubation. We're trying to get our patient intubated rapidly, get a sedative on board, get a paralytic on board, intubate the patient. With these drugs, you could do all that in a couple minutes. Succinylcholine has no reversing agent. So if you give it, you have to wait for it to wear off. So you do have to use caution. And the fact if you can't get your patient intubated, you're gonna have to keep bagging them if you give them succinylcholine because they will not be breathing. So again, something we'll talk about more next term, but if your patient has a difficult airway, let's say they're morbidly obese and you got all this neck and fat tissue, that patient is likely to be a very hard intubation, and you've given them succinylcholine, we didn't get them intubated, and now you can't bag your patient either, then you got a problem. That's real life, has happened to me. It's very scary then. Now you have no airway at all, because not only can you not get the ET tube in, you can't bag your patient either, because all that tissue is just getting in the way. So there is no reversing agent for succinylcholine. There is a very rare side effect. Rose, do you have a question?
I was just wondering, so propofol and etomidate, they have a reversing agent.
Oh yeah, the reversing agent for sedatives is flumazenil. Oh, is it?
Yes.
Yeah, you're right.
Okay, but I just wanted to double check.
Yeah, that's okay. Nick?
Finish that story real quick. What'd you end up doing?
Oh, we ended up giving an emergency trach to that patient, but she ended up having anoxic brain injury.
Due to that or
To the fact that we couldn't ventilate her.
accident?
We couldn't, the succinylcholine was on, we couldn't ventilate her, and that patient in particular, they'd given a ton of meds because she was so obese they weren't effective. So they just gave her so many meds, and then they kicked in. So then we couldn't intubate her, we couldn't ventilate her with a BVM, and now she's still paralyzed. So now she's not breathing, and we can't breathe for her either. So we ended up doing emergency airway, but she suffered brain damage.
Is that
Oh, absolutely.
lot of times doctors will take a quick look to see what the airway looks like before they paralyze
Yeah.
the patient, because they wanna see, is it gonna be difficult to start things and visualize it right away? Then they'll say, okay, go ahead and paralyze them, but typically they won't paralyze them without at least seeing what they're getting into.
Yeah, if you can usually tell, and you guys will learn if a patient looks like they're gonna be a difficult airway. So thank you, Sharon, that's a really good point. Do a quick little peek inside and see if it looks like you're gonna be able to even visualize the airway. Otherwise, you're gonna have to go to plan B. So, flumazenil, that's the reversing agent for sedatives. So succinylcholine has no reversing agent. And then we have our other paralytics, which are, not that, vecuronium, rocuronium, and pancuronium. And those are on your slicks as well. No, well, so they all end in onium. Vec, V-E-C, uronium, and rock, uronium.
Did you say pan?
Yeah, didn't you say pinker?
Huh?
Didn't you say pan?
Pancuronium? Yeah. This a lot of times they'll call Vec, and this one they'll call rocks. So that's what they're talking about. Anybody know the reversing agent for these? No.
It's almost like.
Neostigmine. Stig, S-T-I-G-M-I-N-E, neostigmine. So that's a reversing agent for these. Reversing agents are very important. Although we don't typically give opiates during intubation, we know we have morphine and fentanyl as our pain meds, narcotics. Fentanyl is actually the most commonly used one now because you will see your patients on these. And what is the reversing agent for those? Narcan. Yeah, Narcan. That's the one you use Narcan for. So neostigmine reverses the paralytics, all but succinylcholine. Flumazenil reverses sedatives. And Narcan reverses opiates, which are your morphine and your fentanyl. Yep. So flumazenil reverses your sedatives. Neostigmine reverses your paralytics, just not succinylcholine. And Narcan reverses your opiates, which are your morphine and your fentanyl. The other thing you need to keep in mind with these drugs, you guys, is patients with kidney and liver failure. Guess what's happening? They're not processing them out of the system the way your normal patient would. So it's important. You might not going to necessarily know when you intubate, but when I talk about these drugs, I like to mention this, that if you intubated a patient or you have somebody on a vent and you're giving them these sedatives and paralytics and they have liver failure, it's not going to process through the system properly. And kidney failure, they can't eliminate it. So you know the drugs have to go through the liver and the kidneys to be metabolized, right? Did you talk about that in pharmacology? Okay, yeah, first pass. So if you have liver failure and kidney failure, they're gonna stall out there. So you have to keep that in mind. So those patients, it's harder to get these drugs to wear off on them. And sometimes that's even when you have to use the reversing agents because they just are have such high levels, they don't wake up. So all the things you need to keep in mind. Okay, so that's our meds. So we would start with those. Then our patients being bagged. So what else do we need? We need ET tubes, 2 different sizes. Women, 7.5 to 8. Men, 8 to 8.5. In the real world, everybody gets 8. Yeah, not for everything. So you're gonna wanna have both. Just gonna start with the 8. So what you're gonna do to get this ready is, right now it's in a sterile package, which is how we want it. So you need to check some things on it. Some ET tubes come with a stylet in the package, some do not. But you must have a stylet. You can't intubate without a stylet. So I'm gonna take these out just for to show you, and then I'll show you how you can prep them with keeping them in the package. The stylet's gonna provide rigidity to the ET tube and it allows you to bend it a little bit. So it's very important when you put this in that you do not let this happen.
Oh God.
It's a bad day for the trachea in that patient. So things to point out. You don't want the stylet to go past the Murphy's eye, which is the eye down here at the bottom, right? You guys all saw this last term, right? What's the point of the Murphy's eye?
So when you're sectioning, isn't it when you're sectioning, so it's secluded?
Right,
Not
like,
really.
intubation, the two buckles.
No.
Which one? Oh.
Why do we have a Murphy's eye in this tube? What's it for? Nobody knows.
I know.
If if the end of the tube gets totally occluded, you could have some air go through there. So it's kind of just like emergency. Other than that, it's not really ever used for anything. So, but a good point of reference for your stylet is to not let it go past the Murphy's eye, so you can't. So it should sit right above it. Once you get the stylet to where you want it, it's very bendable, which is why we do that. So there's no way it could go down any further. And if you need to adjust it along the way, you can, but that's my starting point, is to put it there. Now we can bend the tube and do different things to get it into our airway. Generally, you need a little bit of a bend at the end. This hockey puck, a horseshoe. Some people do this. I'm like, what are you trying to do? Put it up in their brain? There would be no reason to have a tube look like this. So be smart. The cuff, what is the purpose of the cuff?
Not allowing the airways to go.
Seal off and protect the airway. The purpose of the cuff is to seal off and protect the airway, which is what most of you guys said. It is not to keep the tube in place. Its sole purpose is to seal off and protect the airway. A cuff will not keep the tube in somebody. If they want to pull it out, they'll rip it out. So the cuff is not there to keep the tube in place. Patients that are hell-bent on taking the tube out, they'll just rip it out. Pilot balloon to fill the cuff with air. You know, we have our markers. So once the tube's actually in place, you're going to use your markers to see where it is in the patient. And then don't forget, we also have our radiopaque line so we can see it on our x-ray. When we put a tube in, where should it sit? How far above the carina?
3 to 5 centimeters.
Yeah, 3 to 5, 2 to 6. It's going to be a little different. So anywhere, I just go anywhere between 2 and 6 is probably fine, because different literature is going to say different things, to be honest.
What's on the test?
The boards is 2 to 6 is fine.
Okay.
Yeah.
Just making sure.
Yeah, you're fine. No, generally, it's very obvious if the tube is out. They'll say it's at 18, or they'll say it's in way too far because it's at 28. So it's pretty obvious if there's a problem. We're not gonna go, it's at 21. That's, yeah. We'll go into what that proper placement is in a minute. Okay, so as you're the person assisting or you're the person getting ready because you're gonna intubate yourself, whatever, these are the things that have to be done to get the ready to intubate. We have to check the cuff. So now I have it back in my package like it was. So I'm just gonna take my syringe and I'm gonna put air into the cuff, and I'm gonna wanna see that it expands. So you keep it in the package like that. Depending on your physician, you may even wanna show him right before you intubate, hey, look, the cuff is good. So if it breaks along the way, it's not my fault. Cause you can see it's very well. There's no problems with the cuff right now. A lot of that'll depend on the doctors and where you're at. You'll get to know them. What you don't want though is the tube going in and the cuff going bad and you being blamed for it. So you check the cuff. If you don't check the cuff and the cuff is bad, then that's your fault. So don't be in that situation. So we're gonna go ahead and take the air back out right now. And a lot of these, you can actually keep the syringe on here, which will be very handy for when you intubate. The other thing that you'll have to actually take it out for, but don't touch the end, is the lube. Again, depending on your physician, they may or may not want it, but you can just squeeze it onto the end without touching it. And then you put it back in the package, and you can actually use the package to kind of smooth it around and get it all over, which helps just with insertion. And now I'm gonna leave my syringe on there so it's ready to go.
So why wouldn't a physician want lube?
Just preference.
Some just don't.
They just
Yeah,
don't?
yeah, they just don't. So just preference. So I'm only gonna get one tube ready and I'll have the other one available as a backup in case I need it. So I have that ready. So as you saw, we need lube. We need OPAs and NPAs. Usually one or the other may or may not be used. NPAs we're not using a lot anymore. What would we use this for most commonly? Yeah, suctioning. The other would be maybe that you have a patient with a mouth injury, but his tongue is falling back and obstructing the airway, so you could put an NPA in, and that would keep the tongue from falling back. I saw that recently on one of the tests. So if you hear a patient with snoring respirations, they also sometimes call it sonorous. So you're at the bedside, the patient is obtunded, which means they're not awake. You hear sonorous respirations or snoring respirations with inhalation. That means the tongue is falling back and obstructing the airway. So,
Is that always the reason for snoring?
yeah, usually even at night when people are sleeping, they have obstructive sleep apnea. Yep. So if someone has oral injury, an NPA will keep that from happening to protect the airway. If they're totally unconscious, then you could put in an OPA, but you have to use caution. Never, ever, ever put in anyone with a intake gag reflex or someone who's awake. That would be a bad day. So, sizing OPAs, you're gonna go from the corner of the jaw to the tip of the mouth. So it would be like this. Corner of the jaw to the tip of the mouth. That's how you size an OPA. You size an NPA by going from the tip of the ear to the tip of the nose. So from the tip of the ear to the tip of the nose. This one's too short. Those come up as well, so make sure you know how to size them. OPA from the corner of the jaw to the corner of the mouth. NPA from the tip of the ear to the tip of the nose. Tip, tip, corner, corner. There are two different kind of OPAs. One has the channel in the middle, one has the channel on the sides. That's just where you can put your suction catheter if you would need to try to go down, if you wanted to try to suction. If someone has this one, you could go right down in the center. Another convenient use for an OPA, if you don't have anything else and you've just intubated somebody, is a bite block. You wouldn't put it all the way in because your patient probably has a gag reflex, but you just put it part way in, and then you can just tape it in place until you've got an actual something that you could use as a bite block. The hospitals all have stuff now, but it's good as a temporary one. If your patient's biting the tube, you're not going to be able to ventilate them or bag them or put them on a vent or whatever. So it's good to have something. Okay? So we have those. We have our laryngoscope and blades. So we have a Miller blade. Miller is straight. And we have a Mac blade. That's the curved one. Mac, like Macintosh apple, sometimes we say. So apples are curved. Macintosh. Some like to remember Mac with the C, then C for curved, whatever you want to do, but you do need to know the difference. So the Mac is curved and the Miller is straight. This is a curved one, sorry. The Miller is straight. My bad. I'm like, that's curved, that is not straight.
I thought it was really
The Millers are straight. So Miller blades for adults, we generally use a 2 or a 3. Size 2 or 3. And Max will use size 3 or 4. That's for adults. So usually we have one of each available for our doctor. And a lot of this is preference. What do they like? If you have a very tall male, you might have to use a Miller just to get it in far enough. So we have two different, so now you have to have batteries in here. And for class purposes, you guys, you need to take the batteries out at the end of every class. They trickle charge and they drain the batteries. So I want you to notice this light right here. This is a very dim light. So this is not going to be acceptable. You can't see inside to intubate somebody if you don't have a good light source. So those batteries are no good. So the laryngoscopes, when they come in the car, so most of the time they'll have the batteries right there. But if not, you can put them in. So we're going to change those and we're going to put good batteries in. So we're gonna check the light source on our blades, and we're also gonna check the bulb to make sure it's securely screwed in. Otherwise, you're gonna have a bulb down somebody's airway. That's not good. The other thing is when you put these blades on here, it's not as easy as you think it is. So you're gonna hold the blade like this, and you're gonna put it here like this. And then you're gonna go down until it snaps, which I think it already did. And then you're gonna pull it straight up. See how much better my light source is now? That's what you want. And you'll get a trained eye for that. When you take it off, you're gonna push it down like that and pull it off. See, that's now you heard the snap. So snap on, lift up. Push it down, pull it out. If you do this, no, I can't get it. But a lot of times people think it's on all the way and it's not. So that takes practice. You might think you're gonna break it, you're not gonna break it. So Miller, same way, snap it on, lift it up, we got a good bulb. So you wanna check your light source on both, have both of those available. The other thing, well, I'll show you in a minute, but Sharon, can you give me one of the upper airway thing up there? You know what I mean? So we need to have an end-tidal CO2 detector. Can you guys pass that up, please? This is our colorimetry. This is CO2 detector, but this one is purely by color change. So what color do we want it to be?
Gold.
Yep, gold for good, yellow for yippee, whatever color you want to call it. P is poopy, so it's bad. So our end-tidal CO2 detector. We have our syringe, whoops, because that's already attached. Tongue depressors and tape, because you are also going to learn the old-fashioned way to tape, because you will have to do it at some point. We'll also show you the tube that they have now. You're going to need a Yonkauer so that you can suction out the airway. We have a Lucan's trap. You're not going to actually use this during intubation, but generally, right after we intubate someone, if they're going to go on a vent, we're going to get a sputum sample to send it to the lab so we can show that our patient doesn't have pneumonia, or they do have pneumonia and it's not our fault, because we don't want them to get ventilator associated pneumonia. And you need a single sterile suction catheter. The reason this is important, and I'm a big stickler on this being in there, is you're going to intubate patients that need to be suctioned immediately. You don't have Ballards when we intubate. We're going to use these later to show that the patient's already on the vent. The Ballards come into play when the patient goes on the vent. So you're all intubated, you're bringing the vent in the room, you put the Ballard on with the vent circuit and all that. So let's say you intubate your patient and they've got severe CHF. What's coming out of the endotracheal tube? What kind? Pink frothy secretions in an amount that you have never seen in your life. It will be everywhere. And you won't be able to bag your patient until you get some of it out. So you need to be able to suction. What?
Oh, I was telling her yesterday, my nurse friend told me not to have, oh my gosh, what am I trying to say? Mesh shoes.
Oh yeah, no. That you will regret that instantly. Yeah. It's best to have something that is waterproof of some sort. Yeah. So you intubate the patient, they've got CHF, pink frothy secretions are billowing out everywhere. You're gonna have to be able to suction them before you're gonna even be able to bag them effectively. Same with a patient who maybe has a really severe infection and has a lot of just secretions in there. You intubate them, they now have a way out. So you're gonna have to be able to suction immediately. So having a regular sterile suction catheter is very, very important. We're not wigging out about being sterile right now. We're more concerned without being able to just suction the patient. So tube goes in, secretions are coming out everywhere. You have your suction catheter and you can start suctioning, and then you can hopefully bag your patient. Okay? Did I miss anything?
I had the McGills up there just so they could see.
Oh yeah, I'll show you these. These are McGill forceps. You might just see the name. These are used when we nasally intubate somebody. You put the tube in here and then you use these to advance it down in the back.
Oh, wow.
It's not used a lot.
Sometimes we've had patients who call it the rat because somebody has been needed to be intubated and they've been mouth breathing and they have this big ball of crusted
Oh, yeah,
secretions
that's
in the
true.
back of their throat, so they'll get the McGills and they'll pull out some nasty looking thing, and that at least clears their airways.
Yeah.
So they can breathe. So if a doctor says I need the McGills, it's just so you know what they look like.
Yeah.
It's between the ground.
They look like this.
Just use-
There'll be one pair available in there.
You said it's used to advance the tube.
In a nasotracheal intubation, but also as Sharon, I didn't even think about that. If somebody's got a lot of gunk in the back of their throat because they've been mouth breathing and everything's really dried out, then you could use that to get back there and get all that gunk out. Because it'll go all the way to the back. Okay, questions so far? All right, so let's talk about actually intubating. So we're gonna say our patient's been being bagged over here. We're doing good, sats are good. We got our meds on board, and now we're actually ready to intubate our patient. So I'm gonna have this ready over at the side, ready for the doctor. I'm gonna use the mat. Everything's checked out. So, and you need your suction. So you have your patient's head in position. You have somebody hold the head, because if not, you're gonna see it lift off as soon as I'm trying to lift up the blade. I also use my arm. So I will use my arm to help keep the head down as well. But you're gonna have an assistant. You also might have to give a little cricoid pressure in someone who has got a very anterior trachea. Then you can use the cricoid pressure to help push it down just a little bit. You don't need to crush it, you just need to push it down a little bit. So when you're getting ready to intubate, you're gonna hold the laryngoscope like this, not like this. So when you put this in, you're gonna lift this way. And if you have your hand up here, you're gonna lift this way. And that is the wrong way. That's gonna break teeth. So my saying is, you're gonna lift up towards the sky, not back towards the eye. You do not wanna break teeth. And if you break teeth during your checkoff, you have to start over again. And I don't wanna hear teeth breaking while you're practicing. Remember, we wanna practice right. This takes a technique as well. You guys will do it wrong at first. You'll have your hands up here and you'll be doing things, but remember, because this is gonna give you a nice solid grip, and it's also gonna make you go this way, not that way. So we're gonna insert the laryngoscope, and usually the first thing we need to do is suction, because the patient's gonna have lots of secretions. So we're gonna suction out the airway, get it all cleared out, and then, I'm probably not in the best position to do this, but I'm gonna put this in, and I'm gonna lift this way, like I said. So see, I'm lifting like this, I'm not going back. So I'm doing this, and I'm gonna lift up this way. And you've gotta use your muscles for this one again. So one thing that's important is you're not looking for a ton of movement in this laryngoscope. Both of them have certain places they go, and I'm gonna tell you that in a minute. And once it's there, your job is to get the back of the tongue and the epiglottis out of the way. So that's mostly, you should think about that, the tip is what needs to be lifted, not all of this here. So if I get the tip lifted, then it moves the epiglottis out of the way and I can see the vocal cords, okay? So what